We're going to be talking about fitness for work and how it impacts on a mentally healthy workplace. Our speakers have worked in this space for long enough to have plenty of examples that they can share with you today, as well as what not to do. We'll hear from each of our presenters, and then we'll have again the opportunity to ask as many questions as you wish as time will allow. So first we'll hear from Associate Professor Ken Pidd, who is from the National Centre for Education and Training on Addiction, to outline the impacts of drugs and alcohol. And then straight after Dr. Kidd, we'll get Dr. Tessa Bailey, who's a registered psychologist, who will be talking around psychosocial safety climate. So please welcome Professor Kidd.
So welcome everybody. I'd like to thank Chris for giving a presentation that's going to make mine look very boring, I'm afraid. So I apologise for that. I have no fancy flash video to show you. But hopefully you'll enjoy what I do have to present, or you'll take something away from what I do have to present. And what I'm going to do is I'm going to give you basically an overview of drugs and alcohol in the workplace as a fit for work issue, starting off with some of the patterns of consumption and the implications for safety and productivity, and also the implications for reducing and managing that risk in terms of a good policy. We'll talk very quickly about the role of drug testing and how you can get further assistance for your workplace. So just to begin, I want to distinguish between two important categories of use. One is workforce use, and workforce use, when I talk about workforce use, I'm talking about the overall use of the workforce. That's use, doesn't matter where it occurs, oops, this is going crazy by itself. I'm not referring to use that actually occurs at work. I'm talking about use that occurs anywhere, at any time. That has both a direct and indirect relationship with workplace safety and productivity and worker well-being. Direct in the form of if people coming to work with a hangover, or an indirect effect through health-related, or behavioural-related or social-related problems that are associated with their use. So, for example, if they're excessively regularly using drugs or alcohol, their health is likely to be affected. They could also be suffering fatigue. They could also be having behavioural problems during the week when they go through a down period of their drug or alcohol use. But also, if they have a dependence problem, they be having social, legal and relationship problems. And all those issues will impact on safety and well-being in the workplace. Workplace use is use that actually occurs in the workplace itself, either just before starting to work, where people come to work when they're intoxicated, or they're actually using in the workplace, and obviously that has a direct relationship with safety and well-being. When we look at workforce use, the overwhelming majority of the risk comes from workforce use. We can see that about 1 in 3 of employed people in Australia drink at risky levels at least once a month, and that's drinking to intoxication levels of 5 or more standard drinks a week, and about 5% are doing that daily. Workplace use is much lower, however it's still of concern. You can see about 5% of the workforce have admitted to attending the work under the influence of alcohol, and around about 5% admit that they usually use at work. That's generally using at lunchtime or having a few drinks after work before they go home. Illicit drug use is slightly lower. When we look at workforce use, about 17% of the workforce have used some type of illicit drug at least once in the last 12 months, and about 10% have used an illicit drug at least once in the last month, and they would be regarded as current users that are probably using on a regular basis. Workplace use again is much lower. About 2% have admitted to working under the influence of drugs, and around about 1% admit that they regularly use drugs at work. The implications for safety and productivity are probably pretty obvious, although the actual data on the risk is pretty low, but we do know that around about 11% of workplace accidents are associated with alcohol use, and around about 12% of workplace fatalities are associated with drug and alcohol use, and that's essentially fatalities where there's been a coronial inquest that involves a toxicology report. So we can't say that the drugs or alcohol actually caused the accident or a direct causal relationship there, but drugs and alcohol were present at a level of concern in that fatality It also could indicate that, given that it's slightly higher than workplace accidents just for alcohol use, that drug and alcohol-related accidents in the workplace tend to be more severe outcomes than if they're not drug and alcohol-related. Productivity, alcohol and drug absenteeism, the last estimate's about $3 billion per year. It's costing employers. That's directly borne by the employer, not what's borne by the community or the government, but directly by the employer. Nearly 1 in 4 workers have admitted to coming to work with a hangover at least once in a 12-month period. And we also have worker well-being, with about 10% of workers saying that they've experienced the negative effects of a co-worker's drug and alcohol use. And that can be bullying, having to cover for that worker, arguments, all that sort of stuff. All those things affect both safety and worker well-being. The patterns of use across the workforce tend to vary, and the higher prevalence groups are what you'd expect to be young males, young workers in particular, blue-collar trades, but these industry groups tend to have higher than average prevalence rates of drug and alcohol use. In contrast to that, we have some broad groups where, not all the time, it does vary, but in general, these broad groups have much lower prevalence rates: females, older workers, those that are professionally qualified, and these particular industry groups have relatively low prevalence rates. And the interesting thing with that is that if you control, if we have and this data comes from very large national surveys of 30 and 40,000 people that are conducted by the federal government every 3 years. And they have a huge range of questions and variables in those data sets that allow you to statistically control for other factors that we know that are associated with drug and alcohol use. So if I was to look at differences by industry or occupation, and I control for age, gender, income, education level, location, all those things that we know are associated with drugs and alcohol consumption, if I control for those variables, these industry differences still remain, which suggests that there's something about the type of work that they're doing or the type of workplace that they're employed in that contributes to their drug and alcohol use in terms of the prevalence of use. The other thing that varies is the types of drugs that are used. So when we look at workforce use, that's use outside of work hours, the number one drug of use is alcohol, of course. It's followed by cannabis, painkillers, and methamphetamine. When we look at work during work hours, it's quite a different thing. The number one drug of use during work is painkillers, followed by alcohol, followed by amphetamines, and followed by cannabis. And you might ask, why do you think that is? Why do you think painkillers are the number one drug? Does anyone think that they have an answer to that?
Socially acceptable. It's legal.
Legal, socially acceptable. Who said pain?
Job stressful.
The job's physically stressful. I'll give you the group with the highest prevalence of painkiller use at work, and I'm talking about painkillers that's not medically prescribed use, is middle-aged and older males who do manual labour. They do it because they need to do it to continue working in those physical stressful jobs. So when you think about drug and alcohol use, there's usually a reason, a valid reason, why people use those drugs during working hours. It's one of the reasons why cannabis is down low on the list compared to high lists outside, because cannabis is not conducive to working smart or quickly. Methamphetamine is, and methamphetamine is also conducive to overcoming the effects of fatigue. So that's why you have high prevalence rates of fatigue amongst construction workers, miners, all those workers where there's long hours and lots of fatigue. So the reason why these patterns differ in terms of patterns across different occupational groups and across different types of drugs is that the research, the evidence tells us that there are different factors that contribute to these differences. And a couple of years ago we developed a model based on that research to try and understand why this occurs. And the first one is that there's a range of external factors. People come to work from a social setting. So they have their own pre-existing beliefs about drug use, they have social norms of where they come from. So there is different demographic differences, education level that will affect what sort of drugs they think are acceptable and their drug use patterns. And what they do is they come into a workplace where there's different workplace conditions. As I said before, if you're working in a construction site or a mine where it's long hours, 12-hour days, 7 days a week, patterns of fatigue, there can be an acceptability of methamphetamine use. It can be something as simple as hot and dusty conditions. Hot and dusty conditions tends to result in workers drinking more alcohol after work because they're dehydrated. Okay, dangerous work, shift work. We heard before about the AMBOs. AMBOs, both dangerous and stressful work, can contribute, and the stresses they face can contribute to the drug consumption patterns where they'll self-medicate with either a legal or illegal drug to deal with those stresses, those physical and mental and behavioural stresses. And because it's because pharmaceutical drugs are more available to them, that particular work group tends to have higher rates of misuse of prescribed drugs because it's easier for them, opioids and stuff like that, because it's easier for them to obtain. But also workplaces recognise that, so they have a whole range of control factors, and there's control factors directly related to drug and alcohol use in terms of a policy, or it could be it could be supervision levels. You can have the higher the supervision level, the lower likely to have drugs and alcohol problems during the workplace. One of the reasons why afternoon shift has higher levels of drug use is not just because it's fatigue, it's because the much lower levels of supervision on the job as well. So a workplace, either the lack of those controls or having those controls in place can influence an impact on different forms of consumption. And then there's how the workplace deals with this issue. What are their normal ways of managing drug and alcohol use? Do they have it where if it interrupts with production, if someone comes in and they're intoxicated or someone's hungover but it's going to interrupt with production, do they overlook that to continue with production, or do they just stop production to deal with that? That can contribute to a culture of how we deal with it. It could also be a poor IR climate, a poor management style. The way that the management does things can lead to different workplace customs and practices are taking place, and plus also social networks within the workplace itself. For example, I can remember many years ago talking to women in the financial sector, and a lot of them would leave that sector because they felt pressured to join the boys after work, to drink after work. So they would leave and move to other ones because they didn't want to join into that thing. So workers can be pressured to drink after work with other workers despite the fact they wouldn't normally do that. And all these factors tend to interact with each other. So you end up in much the same way as an organisational or occupational or workplace safety culture. You can end with a drug and alcohol culture that either inhibits high-risk drug use or enhances high-risk drug use. So the implications for that is firstly the same with any occupational health and safety strategy. You need to begin with a risk assessment. Identify what is the demographic of the workforce that you have, what are the conditions that you have in your workplace that falls into those factors, what does do you have an appropriate policy. Identify those things that place you at risk, and then try and identify response strategies that you can implement to remove or reduce those risks. And one way to look at it as well, and most users will be familiar with this sort of model, the traditional approach that people have used around dealing with drug and alcohol use has been quite different to the way you think of it in a normal occupational health and safety approach. The approach has usually been all on the high-risk end users. It's about identifying the people that we think are a drug addict, or identifying the people we think are an alcoholic, and let's deal with them, let's treat them some way, either put them into rehabilitation or treatment or just sack them to get rid of them. The problem with that is only 18%, when you look at alcohol, only 18% of your workforce fit into that category, to where they're high-risk regular drinkers. The rest of them, over 60% of them, nearly 70% of them, are occasional and frequent risky users, or occasional and frequent low-risk users. And the reality is that when you look at things like workplace absenteeism, that group accounted for nearly half the absenteeism. And a similar thing will apply to safety, and in fact, more so. That lower group probably is more of a safety risk when they do drink at those high levels than someone who's a risky drinker. And there's a whole range of things around state-dependent learning which will back that up. So what you really need to do is turn that, take a prevention approach and turn that around a little bit and focus on the whole of the workplace, okay? And not just worry about tertiary treatment at that high end, but also look at prevention across the whole spectrum, okay? And one of the most important ways to start with is a policy as a foundation. And the reason why I'm bringing policy up is because if I was to ask the workplaces that you come to, and this has been my experience over the last 25 years, if I was to go to your workplace and I was to ask the bosses, this very senior management, do you have a drug and alcohol policy? They would all say, yes, we've got one here, everyone knows about it, it all works. I'll move down a level and talk to middle management and I'll say, do you have a policy? Around about 70-80% of them will say yes. I'll ask 6 of them, how does it work? And I'll get 6 different versions of how it works. I'll move down to the floor, and if I get 50% saying we've got a drug and alcohol policy, I think you're doing real well with the dissemination process. And that's the problem. So if you have a policy, you should be constantly reviewing the policy, and you still use this basis that I'm about to outline now. And so a good policy starts with a consultation, development and review, when you do and have development and review in it. So if you're going to rewrite a new policy or review an old policy, involve your workforce in it. Send drafts out to them. Let them have some sort of input in them. Not only will some of them probably come up with some good ideas that you've overlooked in your policy, but it's that thing about buy-in that Chris talked about too. They feel like they're involved. They will own the policy. Make sure it's universal in application. And while you can get templates off the internet to do that, or you can get it from some other workplace, or every workplace is different. Make sure you go through it and make sure that it's specific to your particular workplace. Make sure it's comprehensive. It contains not just how it's going to, what the motherhood statement is underneath all that, but make sure you have proper implementation procedures so that people know what they're supposed to do, and then have provision for education and training, education strategies to disseminate that policy to your workforce, but also training strategies so that people who are expected to implement it know how to implement it. And again, when you talk to workplaces, I'm lucky if 10% of workplaces I've worked in over the years have some sort of training for their managers on how to implement the drug and alcohol policy. And that's the reason why they all have a different view. And when supervisors implement that policy in different variations, it becomes meaningless to the workers. They just say, look, they don't know what they're going on about. How do they expect us to do it? So a good policy, there's 3 important components to it. Dissemination and awareness. The employees must know what's in the policy and how it works. Supervisors, team leaders and managers must know how the policy is implemented, but also they need to have a little bit about knowing how to identify risk and respond to risk too, not just implementing their policy. It also needs to have some sort of referral process. You need to have something to some way of dealing with your workers, and that's not particularly hard thing to do, especially here in South Australia now that Drug and Alcohol Services South Australia has their Know Your Options website, and if you get onto that website, anyone can go to that website and pump in their postcode, and it will give them all the treatment agencies that are in their particular area. I just want to quickly, before I finish up, talk about drug testing. And the main thing I want to say about drug testing, look, it does play a very important role, but if you focus on testing as your response alone, it's going to be very, very limited, okay? The evidence for testing is that the testing actually improves workplace safety or deters use is very, very limited. And what can happen is if you implement it in an inappropriate way, you always need to remember the law of unintended consequences. And one unintended consequence is the reason for implementing testing is to get people to change their behaviour by reducing their use or reducing their risk. Quite often what happens is they change their behaviour to avoid detection without reducing any risk, and in fact some cases increasing the risk. And one of those things that can have the research that I've looked at as evaluated testing programs, in particular post-accident testing, a couple of studies have been done and they've all said, yes, there's been a significant reduction in accident rates after they've introduced this program. Then when they start unpacking it, they realise the serious accidents, the time loss, haven't gone down at all. What's gone down is the near misses and the minor injuries. Why? Not because they're not happening anymore. People just aren't reporting them anymore. Okay, and then it has a negative impact. The big thing about testing is employee consultation. employees need to be on board to why it's needed, how it's going to work. And again, if you involve them in the process of developing that testing procedure, they will come on board with you. And with that, another thing that Chris said, get SA Health to pay for it. Well, SA Health is paying for a new 3-year project that NCETA is running, where we're going to try and help South Australian workplaces reduce drug and alcohol risk. So we're creating at the moment a whole range of resources that employers in South Australia will be able to use. We're taking a co-development approach with that. We have a project reference group. We've involved the construction industry, we've involved the manufacturing industry, we've involved Australian Industry Group, who are providing input into what some of those resources are. And some of you may know Valerie O'Keefe. I'm retiring at this end of the year, and Valerie is going to take over that project. I'm so pleased that we got Valerie, because I think she's going to do a much better job of it than what I will. And just finally, this is some of the resources that we've already developed over the years. Now we're going to try and rehash those, redo those, and redevelop those and new ones in a way that it's easy for South Australian workplaces to use those resources. So in that, thanks very much. And if you want more information, contact NCETA.